we'll talk now about health impact assessment. And health impact assessment of potential health effects, whether positive or negative, of a particular intervention on a population. So you assess like a new drug, and you want to know how much impact it has on the population, or a new intervention policy or something. So it is the assessment of potential health effects, whether these effects are positive or negative, of a particular intervention on a population. And these HIAs can evaluate population-directed interventions before they are implemented, and can provide recommendations on how those interventions can potentially affect the health of a population, whether in a positive or negative way. And in order to have this assessment accurate, we need to perform some calculations in order to determine the efficacy of a treatment or intervention. One of these calculations is the number needed to treat, which is the number of patients needed to be treated in order to achieve one favorable outcome. Like how many patients you need to treat until you can benefit one patient. Also, we need to know the number needed to harm, which is the number of patients needed to be treated until one harmful outcome occurs. Like if you have a new drug with a bad side effect, one significantly bad side effect, then you need to know how many patients needed to be treated with that drug until one harmful outcome happens. Of course, we always want the number needed to treat to be as low as possible, because this means we're going to benefit many patients, and we need the number needed to harm to be as high as possible. The higher, the safer. And in order to calculate these two parameters, we also need to calculate the absolute risk reduction, which is the absolute arithmetic difference in event rates. So here we have the experiment event rate minus the control event rate, and this gives us the absolute risk reduction. Also, another value, we need to calculate the absolute benefit increase, which is the absolute arithmetic difference in event rates. Here, again, it is the experimental event rate minus the control event rate. The absolute risk increase is the absolute difference in rates of bad events, like side effects of a drug, when the experimental treatment harms more patients than the control treatment. Experimental rate, event rate, and control event rate, these are understood like how many patients benefit in the experiment versus how many patients also do not show bad outcome in the control groups. Let's give one example here. Say that there is a new anticoagulant drug used to prevent blood clots in one hypercoagulable condition. And I just give it a fake name. I call it Nabiclot. And this new medication can result in hemorrhagic stroke as a rare adverse effect. So let's say 1,000 patients are enrolled in this study, and there is a study about this drug, and you want to look closer into the results of this study in order to decide, is it beneficial and safe to use this drug or not? So when you review this study, you will come up with a result or a conclusion that the benefit of this drug outweighs the risks, so it's good to use it. Based on what? Based on the calculations of the number needed to treat and the number needed to harm. So let's say 1,000 patients enrolled in this study. 500 got this new drug, Nabiclot, and this is going to be the experimental group, and 5,000 got placebo, and that will be the control group. And here are the results. 70 patients taking Nabiclot developed a blood clot. 70 patients out of 500, this constitutes 14%. While 150 patients on the placebo developed a blood clot. 150 patients out of the 500, that's 30%. So what is the absolute risk reduction? It is the control event rate. So how many patients in the control group develop blood clot? 30%. The rate is 30%. 30% of the patients of the control group develop blood clot, minus the experimental event rate. 14% in the experimental group developed blood clot. So what's the absolute risk reduction? It is the arithmetic difference, which means 30% minus 14%, which is 16%. So there is a 16% lower incidence of blood clotting or blood clotting events occurring in patients treated with Nabiclot. The number needed to treat is the reciprocal of the absolute risk reduction. So mathematically, here is how we calculate it. It's 1 over absolute risk reduction. The absolute risk reduction is 16%. So the number needed to treat will be 1 over, or 1 divided by 0.16, which is 6.25. And of course, there is no quarter of a patient. So you have to round it up to the nearest whole number, which is 7. So here, the number needed to treat is 7 patients, which means 7 patients need to be treated with this Nabiclot new drug to prevent blood clotting in 1 patient, of course, within a specific time period. But we also need to calculate the number needed to harm. So let's say that again, the 1,000 patients enrolled in this study, 500 got Nabiclot and 500 got placebo. 20 patients taking Nabiclot developed hemorrhagic stroke. 20 patients out of 500 means 4%, whereas 15 patients on placebo developed hemorrhagic stroke. 15 patients is 3% of 500. So what's the absolute risk increase? So it seems that the risk of hemorrhagic stroke increases with Nabiclot. The experimental event rate of this hemorrhagic stroke in the experimental group is 4%, and the rate of developing hemorrhagic stroke in the control group is 4%. So there is an absolute risk reduction of 4% minus 3%, which is 1%. So there is a 1% higher incidence of hemorrhagic stroke adverse effect occurring in patients treated with Nabiclot. And again, the number needed to harm is the absolute, is the reciprocal of the absolute risk increase, which is the reciprocal of 1% or 0.01, which is 100. So the number needed to harm here is 100 patients, which means 100 patients need to be treated with Nabiclot before you can see hemorrhagic stroke in 1 patient within a specific period of time. So what are the general conclusions that you get out of this study? The number needed to treat, 7 patients. Always the lower the number needed to treat, the more beneficial the intervention. The number needed to harm is 100. And always the higher the number needed to harm, the safer the intervention. So based on the results of that study, the use of Nabiclot is recommended in patients with that particular hypercoagulable condition because the benefit outweighs the risk. So this is what we need to know about the health impact assessment. I'm going to end this segment here.